We will discuss cardiovascular system. Overview. The preparation time for cardiovascular system clinical station is 3 minutes. Try to utilize whole 3 minutes. Try to read out the scenario 2-3 times and prepare the strategy. Then examination and discussion time allotted for this is 8 minutes. Warning bell will be given at 6 minutes and marks allotted 8. Introduction. Always greet once you enter the house. Introduce yourself. Define your role and responsibility. Wash your hand with sanitizer and take COVID precautions. Ask for consent to examine and exposure. Make rapport, asking what is your favorite game, who is your favorite footballer, like this, and explain what you are going to do. Look for any dysmorphism, whether the child is having any specific faces like Down faces, Turner syndrome faces or not. Look for any distress or not, and any disease stigmata is present there or not. Then measure height, weight and head circumference and look at the surrounding. Spot the devices and any drugs around there or not. Look at the hand. Look for the pallor, icterus, cyanosis and clubbing and stigmata of infective endocarditis like in splinter hemorrhage, painful oslar node and Janeway lesion. Then check pulse. Try to assess the rate, rhythm, volume, any radial, any radiofemoral delay. Look for water hammer pulse. It is important for hyperdynamic circulations, particularly for hyperthyroidism, aortic regurgitations, and fever. Check the blood pressure, temperature, and capillary refilling time. Examine the eyes. Look for any suffused conjunctiva which is present in cyanotic heart disease. Look for pallor and icterus. Check mouth. Look for dental hygiene, central cyanosis, or look for any high arch palate which is present in Marfan syndrome. Examine the neck. Measure the JVP. If there is time constraint, just mention that you will measure. Then start inspection. Inspection to be done from the front, from the back, from the foot end and from the head end. Look for what is the shape of the chest. Is there any bulging there or not? Is there any scar? What is the respiratory rate? And any work of breathing is there or not? And any visible pulsation. And also look for any rash. While looking at the scar, median sternostomy scar is present in cardiac valve replacement surgery and pulmonary artery bending. If there is right sternostomy, thoracostomy scar, it could be because of pulmonary artery bending or BT shunt. Left thoracotomy scar is present in pulmonary artery bending, PDA ligation, or BT shunt, or repair of coarctation of aorta. Infraclavicular scar denotes pacemaker insertion. Left mid axillary scar could be because of the subcutaneous ICD. Then go for palpation. Palpate all these 6 areas. Look for any impulse or thrill or any palpable heart sound. Don't forget to check dextrocardia. Try to locate the mitral area and try to assess is there any impulse or thrill present or not, because in mitral area, if there is any forceful apex is there or any thrill is present, it could be because of mitral incompetency. Then you have to palpate left lower parasternal area, which is tricuspid area. If there is any thrill present, it could be because of VSD. In aortic area, you have to look for the pulsation. It could be because of aortic stenosis. And in left second intercostal space, which is pulmonary area, look for any impulse or any thrill. It could be because of pulmonary stenosis. And palpate the supraclavicular area and over the carotid. If there are any impulse or thrill present, it could be because of aortic stenosis. Then auscultate all those 6 areas: mitral area, tricuspid area, aortic area, pulmonary area, supraclavicular area, over the carotid as well as the back. And auscultate the patient first, as they can be agitated while doing the examination. Look for S1, S2, S3, S4. If S3 is present, it could be because of the gallop rhythm, signs of heart failure and hyperdynamic circulation. And try to assess the murmur. If murmur is present, try to assess whether it is a systolic murmur or diastolic murmur. And the timing. What is the intensity, whether it is a loud murmur or a faint murmur. And the characteristic of the murmur. Then try to assess the grade. Grade could be 1 to 6. Whether it is changing with the inspiration or expiration. Whether it is changing with the posture, which is present in atrial myxoma. Is there any radiation of murmur or not? If it is radiating towards axilla, MR should be suspected, and if it is radiating towards carotids, aortic stenosis could be suspected. And if it is radiating towards back, pulmonary stenosis could be suspected. Then the percussion. Usually we don't do the percussion, but we can do to check mediastinal widening. Percussion is always avoided because it is a painful situation. In order to finish the examination, check the femoral pulses, check pedal edema, complete the respiratory system examination, GI system examination, look for tender hepatomegaly, which is a sign of right heart failure. There are lots of syndrome associated. Alagille syndrome, you may find pulmonary stenosis and tetralogy of Fallot. Church syndrome, in Church syndrome you can find tetralogy of Fallot, PDA, ASD, VSD, AVSD. In Dijor's syndrome, tetralogy of Fallot, VSD, interrupted aortic arch are associated. Down syndrome, mainly AVSD, is very common cardiac problem. Sometimes ASD, VSD are also associated. Fetal alcohol spectrum disorder associated with ASD and VSD. Marfan syndrome, you may expect aortic dilation or regurgitation and mitral prolapse. Turner syndrome is associated with coarctation of aorta and aortic stenosis, whereas Noonan syndrome is associated with pulmonary stenosis And Williams syndrome is associated with supravalvular aortic stenosis and peripheral pulmonary stenosis. Thank you.